PFT pulmonary function test just not mean spirometry. What we do, we think pulmonary function test and spirometry are the same thing. They are synonymous. It is not like that. Spirometry is just a part of pulmonary function test and it evaluates airways and lung functions. However, PFT evaluates one or more major aspects of the respiratory system like airway functions, lung volumes, gas exchange, and other tests. Now, these are the things which evaluate airway functions. One of them is spirometry and flow volume loops. Peak expiratory flow rate, maximum inspiratory and expiratory pressure, maximum voluntary ventilation. Lung volumes cannot be evaluated with your spirometry. For evaluation of lung volumes, you need other methods like helium dilution method, nitrogen washout method, or most specifically, body plethysmograph, which is not done in most of the places and also not done in Liaquat National. What we do spirometry. Now, how to evaluate gas exchange? Spirometry will not help you in evaluating your gas exchange. Other tests for these are arterial blood gases or most commonly known as ABGs, pulse oximeter. During this COVID pandemic, I believe each and every one of us heard about this pulse oximeter. आप अभी किसी से भी पूछें, हर किसी के घर में या एक मस्ट आइटम है ये in COVID pandemic. Capnography is basically what we use to measure carbon dioxide. Diffusion capacity for carbon monoxide or more commonly pronounced as DLCO. Other tests which are cardiopulmonary exercise testing, bronchial provocation challenge test. This bronchial provocation challenge test is usually not done. These challenges are given when patient is very highly likely of asthma, but spirometry is not suggestive of asthma or reversible obstructive lung disease. Because during asthma or in asthma during stable state, spirometry can be completely normal. So what we do, we give some challenges, and in a normal patient, those challenges will not result in spasm or more spasm. But in an asthmatic patient who is allergic to most of the things will show more bronchospasm as compared to the normal individual. This is called bronchial provocation test, usually done with histamine, mannitol. You can even use hypertonic saline for this. Now our basic main topic, which is spirometry. Most of the students are mute. If I want to ask anyone question, how will I do that? They cannot answer me. Yusra?
Yes, sir.
I am seeing that their mics are mute and it is being muted by the host. So they cannot answer me if I ask any question. Is that right?
Sir, they can unmute themselves and answer you.
Okay, ठीक, right. Anyone with who can tell me indications for spirometry? Anyone voluntarily?
Shortness of breath.
Okay. Just shortness of breath. Basically, indications of spirometry can be classified into diagnostic. Diagnostic means to diagnose any disease, like evaluating symptoms, signs, or abnormal laboratory tests. To measure the effect of disease on pulmonary function. Let's suppose someone has interstitial lung disease. So what you do, you measure his or her pulmonary functions to see how much damage they have done. In screen individuals at risk of having pulmonary disease to assess preoperative risk. Sometimes in our clinic, patients are referred to us that this gentleman is having some laparotomy done or appendix removed, but he is COPD patient. He has been smoking for past many years, can we proceed with surgery? So one of the tests we perform on these individuals is spirometry. Assess health status before beginning strenuous physical activity. This is usually not done. Now monitoring. Let's suppose you diagnosed a patient with asthma or COPD and you advised him some medications. The best step to monitor any of these is symptoms. Patient symptoms are uh, relieved or not. Other thing, you can repeat that spirometry after some time to see whether your intervention is working or not, like in interstitial lung disease or some adverse reactions to the drugs with known pulmonary toxicity. Sometimes people from oncology department or patients from oncology department are referred to us that we are planning to start chemotherapy of this patient. And one of those is bleomycin. What bleomycin causes? Bleomycin causes interstitial lung disease or infiltrates, leading to restriction. So if that patient is already having underlying disease or uh, restrict restriction, that patient's symptoms will worse very much. So what we do, we get a spirometry done before starting chemotherapy. Disability and impairment evaluations, and sometimes like public health epidemiological surveys, derivations of reference equation. This disability and impairment evaluation not done in our setup on Pakistan but abroad. What they do, if they hire you for some work, let's suppose all of you have seen marble workers in Pakistan. हर किसी के ने मार्बल्स का काम देखा होगा, वो बेचारे किस तरह काम करते हैं कि उसमें मार्बल को वो पूरा उसको उसकी जो चीजें होती हैं वो की जाती हैं, उसके डस्ट पार्टिकल्स होता है, ठीक है, and that dust particle can lead to silicosis and other interstitial lung disease. So basically when these patients are giving job abroad for something like this, they get a spirometry done before getting them to do this work, and if they find any impairment, they won't allow them to do this work. Or some legal issues can be there, you can sue them if they were not provided with enough equipment to prevent these interstitial lung disease or this restrictive lung disease. So basically they get impairment evaluation before giving people these jobs. Now basically contraindications for spirometry. Hemoptysis of unknown origin, even the known origin. If a patient has hemoptysis and ongoing hemoptysis, you cannot ask the patient to do spirometry because it is a forceful voluntary expiration and can lead to further hemoptysis. Patient with pneumothorax, patient with unstable hemodynamic like angina or who recently had MI, patient with known thoracic aneurysm can lead to rupture of that aneurysm. Same goes for abdominal aneurysm, basically aneurysm anywhere. Recent eye surgery, recent abdominal and thoracic procedure, history of syncope associated with forced exhalation. किसी की हिस्ट्री है कि वो ज्यादा तेज सांस लेने से या फोर्सफुल एक्सपायरेशन करने से उसे सिंकपी अटैक हो जाते हैं, तो अवॉइड स्पायरोमेट्री इन दीज पेशेंट्स. These are some few contraindications for spirometry. Now, lung volumes and capacities. Basically, spirometry lets you find out these things. What are the four volumes? Inspiratory reserve volume, tidal volume, expiratory reserve volume, and residual volume. We will discuss this one by one. And two or more volumes make a capacity. And four capacities are vital capacity, inspiratory capacity, functional residual capacity, and total lung capacities. Concentrate on this film. This is tidal volume. What is tidal volume? Tidal volume is the normal amount of air breathed in or out during normal inspiration or expiration. Just see this. This is tidal volume. Any breath taken above tidal volume inside or any breath inhaled is inspiratory reserve volume. The combination of this tidal volume and inspiratory reserve volume is inspiratory capacity. Now you will see this ERV. This is expiratory reserve volume. Any amount of air that can be expired after normal breathing is called expiratory reserve volume. The combination of all these, inspiratory reserve volume, tidal volume, and expiratory reserve volume, is called vital capacity. And at the end, you will see residual volume. What is residual volume? It is the amount of air remaining inside the lung after your expiratory reserve volume or after your maximum expiration. The amount of air which remains inside the lung to keep the lungs open and do not letting the lungs collapse is called residual volume. अगर ये volume भी नहीं होगा तो patient का lung collapse हो जाएगा. So this residual volume can never be expired. It will always remain inside the lung to keep the lungs open. Now combination of all these or combination of vital capacity with residual volume is called total lung capacity, and combination of residual volume and expiratory reserve volume is called functional residual capacity. I hope all of you are understanding this. If anyone has any question, please ask. Anyone has any question, please ask. Okay, I'm proceeding further. Now, tidal volume. Now, I already explained you that volume of air inhaled or exhaled with each breath during quiet breathing, मतलब normal breathing के दौरान. Inspiratory reserve volume, maximum amount of air or volume of air inhaled from the end inspiratory tidal position, that which means from normal breathing, is called inspiratory reserve volume. Maximum amount of air which can be inhaled after your normal tidal volume is called inspiratory reserve volume. Same goes for expiratory reserve volume. Maximum amount of air that can be exhaled from resting and expiratory tidal position is called expiratory reserve volume. Now, residual volume, volume of air remaining in the lungs after maximum inhalation, indirectly measures. It is indirectly measured by FRC and minus ERV. It cannot be measured by spirometry. Lung capacities. Total lung capacity is sum of all the volume compartments or volume of air in the lungs after maximum inspiration. Vital capacity. TLC minus residual volume. Never try to understand this like this, TLC minus residual volume. It is the maximum volume of air which can be exhaled from after maximum inspiration. It is called vital capacity. It comprises of inspiratory reserve volume, tidal reserve volume, and expiratory reserve volume. The total amount of air which is exhaled after maximum inspiration is called vital capacity. If this maneuver is done forcefully, it is called forced vital capacity, FVC, which we measure in vital spirometry. Now, inspiratory capacity. Sum of inspiratory reserve volume or tidal volume, or the maximum volume of air that can be inhaled from an expiratory tidal position. Now, these are some values for normal lung volumes. As you can see, the total vital capacity is measurement of inspiratory reserve volume, which is in men is 3.3 liters and in women it is 1.9 liters. Tidal volume or the normal amount of air breathed in or out at any point is around roughly 500 ml for both men and women. Expiratory reserve volume in men is almost 1 liter or 1 liter, and in women it is almost 1 liter. Total lung capacity is 6 liters in men and 4.2 liters in women. And FPV1, or the first part of FVC, is called FPV1. The maximum amount of air exhaled during the first second of FVC is called FPV1. It is roughly greater than 80%. Now, spirometry is a measure of airflow and lung volumes during a forced expiratory maneuver from full inspiration. Now, what information does a spirometer yield? Spirometer can be used to measure FVC and its derivatives. FVC is forced vital capacity and its derivatives are FEV1, or you can say the amount of air exhaled in the very first second of FVC is called FEV1, forced expiratory volume in the first second. Other things which can be measured as peak expiratory flow rate, maximum voluntary ventilation, slow vital capacity. Same maneuver if done slowly is called slow vital capacity. Pre and post bronchodilator studies. Now this is a graph showing forced vital capacity. The volume of air exhaled as quickly as possible after taking a deepest possible breath is called forced vital capacity. आपने maximum air inspire किया, inhale किया और उसको फिर आपने forcefully exhale कर दिया. आप you can see this is a volume time curve. Volume is mentioned in 1, 2, 3, 4, 5 liters and time in seconds 1, 2, 3, 4, 5. This total graph is forced vital capacity. This is forced vital capacity. And after forceful exhalation, the amount of air remaining in the lungs is residual volume. Let's suppose forced vital capacity is 4.5 liters and the remaining amount is this residual volume. Now, the first portion of this forced vital capacity in first second of the time volume curve. This is first second. आप एक straight line ऊपर खींचें ग्राफ तक और उसको आप measure करें. This is 3 liters. FEV1 of this patient who has forced vital capacity of 4.5 liters is 3 liters. It is almost greater than 80%. So this is a normal volume time curve. ये सारी चीजें स्पायरोमेट्री का जो स्पायरोग्राम होता है उसमें मेंशन होती है. यहाँ पे बताने का मकसद सिर्फ ये है कि आपको पता हो कि ये एक वॉल्यूम टाइम कर्व है जिसमें आपने फोर्स वाइटल कैपेसिटी को मेजर करना है और उसके फर्स्ट सेकंड का जो अमाउंट होता है जो एक्सहेल किया जाता है इट इज कॉल्ड फोर्स्ड एक्सपायरेटरी वॉल्यूम इन फर्स्ट सेकंड, FEV1. The volume of air exhaled forcefully during the first second of the FPC maneuver is forced expiratory volume. Now there is another thing, forced expiratory flow. It is the mean expiratory flow during middle half of the FPC maneuver. Reflects the flow through the small airways. These are basically three things which we measure in spirometry. FEV1 over FVC, FEF 25 to 75%. The main important thing is this FEV1 over FVC. The ratio of FEV1 to FVC expressed as percentage indicate what percentage of FVC was expelled from the lungs during the first second of forced exhalation. An important value in the diagnosis of obstructive and restrictive lung disease. I'll tell you how. Any questions till now? Please ask. I know I'm going a little bit fast because I also have to cover ABGs. Please, any questions at this point?
Oh, sir.
Okay, so we will proceed further. Now, flow volume curves and spirogram. There are two ways to record results of FVC in spirometry. Flow volume curve and time volume curve. That time volume curve was the previous slide. This is time volume or volume time curve. There is also another thing which is flow volume curve. Flow meter measures flow rate in liter per second upon exhalation. Flow plotted as a function. I'll tell you how it's done. This is volume time curve and this is flow volume curve or flow volume loop. This is flow and this is volume. Basically both measures FVC. This FVC is measured in respect of time. So there is a plateau you can see and this is measured in terms of flow. You can see during this upward curve or above curve is expiration and this is inspiration. During expiration of forceful vital capacity in first second, you can see most of the lung volumes is expelled in the first second. This is FEV1. It goes till the top, then it slightly at the end of expiration goes down. This whole curve is FVC. This is an expiratory limb of FVC and this is an inspiratory limb. When you perform a spirometry, you ask the patient to take deep breath and then forcefully expire. And then again take deep breath. When they expire, they record expiratory limb. And then when after expiration, they inhale maximum forcefully, this is an inspiratory limb. This whole thing is called flow volume loop. Basically, you can diagnose your disease even just seeing this flow volume curve. Now, what is an acceptability criteria? Before reading in spirometry, you should know that this spirometry is performed properly or not. There should be no cuff or glottis closure during the first second of exhalation, no early termination or cutoff, no variable effort, no leak, have a good start. I'm going to show some examples for this. This is an acceptable spirogram. But you can see patient, this is volume time curve, patient expired and it goes smoothly till the plateau. This is an acceptable spirogram of flow volume time curve. And this shows flow volume. This is an early expiration, then it goes down. These two are acceptable spirogram. Now see what happened during the cuff. If patient cuffs during your test, there will be notches. You can see some notch in this volume time curve, which are more visible in this flow volume curve. You can see there is a deep notch, then again, these are not acceptable. Basically, if you see any spirometry like this, you should not comment on it. You should ask your technician to perform it again. This is variable effort. You can see there is notch even in the first expiration, first second, and you can see the flow volume curve में वो किस तरह का notch आया. These are unacceptable. You should not comment on these. You should only comment on these acceptable spirograms. Factors that affect spirometry results are height, age, weight, gender, ethnicity, disease. Now some steps of interpretation of PFTs. Step 1, look at the flow volume loop to determine acceptability of the test. जो मैंने आपसे अभी बात की. अगर acceptable नहीं है तो you cannot proceed further. Step 2, look at the FEV1 to determine if it is normal, greater than 80% predicted. Look at FVC to determine if it is normal, greater than 80%. Step 4, see the ratio of FEV1 or F over FVC. Or you can also go in reverse direction. First, see the ratio. The ratio should always be greater than 70% in a normal individual. If FEV1 over FVC is less than 70%, okay, I'm going to ask you people some questions. Please, anyone who can reply, if the ratio is less than 70%, what are the chances or what are the disease you suspect in this patient? Is it an obstructive lung disease or restrictive lung disease?
Obstructive lung disease.
Please state your name and tell me loudly. I cannot hear you.
Obstructive lung disease.
Who is speaking, please?
Mine.
Mine, you are saying if ratio is less than 70%, it is obstructive lung disease.
Yes.
Is that what? Okay. Anybody who disagree with her, Mahi? Okay, basically Mahin is right. Any ratio less than 70% is an obstructive lung disease. So what you do, the next step would be you would need to determine, is it a reversible obstructive lung disease or irreversible obstructive lung disease? Reversible obstructive lung disease is asthma and irreversible obstructive lung disease is COPD.
COPD.
COPD. Okay, reversible is asthma and irreversible is COPD. If the ratio comes greater than 70%, there are two possibilities, whether this is a normal spirometry or it is restrictive lung disease. Basically, step 5 is a bit more at the level of final year, but I believe I'm going to tell you this just so you know a little bit more about it. If FEV1 FVC ratio are all and FEF 25 to 75% are all normal, then patient has a normal PFT. But if both FEV1 and ratio is normal, but there is some FEF 25 to 75 is less than 60%, then think about early obstruction or small airways. Some smokers or some asthmatic patients show normal spirogram, but this FEF 25 to 75% is less than 60%. It means their early disease has started in these patients, and if he or she is a smoker, ask them to quit smoking. If FEV1 is less than 80% and FEV1 over FVC is also less than 70%, there is an obstructive defect. If FVC is normal, it is pure obstruction, because in obstructive lung disease, it is the first part of FVC which is more affected. FEV1 is more affected. So basically, in a pure obstruction like asthma and COPD, FVC remains normal, and FEV1 is less than 80% and FVC and the ratio is less than 70%. But if these patients also have FVC less than 80%, then there is possibility of additional restriction is there. These are called mixed defect. So what you see the ratio and you see the FEV1 and FVC. If FEV1 is less than 80% and FVC is also less than 80% and ratio is greater than 70%, there is restrictive defect. And for restrictive lung disease, you need to evaluate further by getting lung volumes and DLC or diffusion lung capacity of carbon monoxide. Acha, can someone tell me if FEV1 was greater than 80% and so does the FVC is also greater than 80% and ratio is also greater than 70%? But we will call this spirometry. Everything is greater than 80% and FVC ratio is greater than 70%. What will we call this spirometry? Obstructive, restrictive,
Restrictive. Restrictive.
Again, please listen what I'm saying. FEV1 is greater than 80%, FVC is also greater than 80%, and ratio is greater than 70%.
It's normal.
It's normal. This is a normal spirometry. If you find ratio greater than 70% and FEV1 and FVC greater than 80%, this is normal spirometry. Now, spirometry, obstructive versus restrictive defect. Obstructive defect is characterized by limitation of expiratory airflow so that airways cannot empty as rapidly compared to normal. And examples are asthma, COPD, cystic fibrosis, and bronchiectasis. Bronchiectasis comes in category of cystic fibrosis, but not sometimes patient develop bronchiectasis after TB, tuberculosis. So bronchiectasis is also an obstructive lung disease. If you can see, only asthma is a reversible obstructive lung disease, and COPD, cystic fibrosis, and bronchiectasis are irreversible lung disease. Now, for restrictive disorder characterized by reduced lung volumes or decreased lung compliance, it can be due to interstitial fibrosis like ILD, obesity, scoliosis, lung restriction, neuromuscular disease, cystic fibrosis. Cystic fibrosis comes in both category because it leads to parenchymal distortion, which leads to restriction. Now, some differences between normal spirogram and obstructive and restrictive. This is a normal volume time curve, and this is a normal flow volume curve. You can see there is a plateau or there is a peak in the expiration in the first second, then it decreases downhill. What happens in obstructive lung disease? Lung volumes are reduced. You can see यहाँ तक ये 5 liters तक जा रहा था, यहाँ पे 3 liters तक जा रहा है, and there is prolongation of volume time curve. अच्छा, volume time में आप obstruction इतना अच्छा नहीं देख सकते जितना flow volume में देखते हैं. Can you see this concavity? The concavity is coming because patient is having difficulty in exhaling all the air remaining in the lungs, which is called obstructive lung disease. So in this, steep downhill is not seen in obstructive lung disease. You see a concavity because it is difficult for these patients to exhale or expire fully. So you get a deep concavity. This is called obstructive spirogram or obstructive flow volume curve. Now, in restrictive lung disease, basically there is no obstruction in restrictive lung disease. So the shape of the spirogram will remain same. The shape of the spirogram will remain same, like you can see here in volume time curve. But you see the volume is drastically reduced. Drastically reduced. From 5 liters, it has dropped to 2 liters. It is more or less the same, but slightly downhill is more early than the normal spirogram, but you can see no concavity in here. So this is a restrictive pattern. Oh, this is the flow chart for diagnosing spirometry. You see, मैं इसको थोड़ा सा simple करके आपको बताऊंगा. First is to see the ratio FEV1 over FVC. If it is less than the normal or less than 70%, what are the chances? What are the chances if it is less than 70%? Can anyone tell me?
COPD.
Obstructive.
Obstructive lung disease. Very good. If it is less than 70%, it is obstructive lung disease. Okay, what you do? You see the vital capacity. Vital capacity is greater than 80% or normal. So it is obstructive lung disease. This is an obstructive lung disease. Basically, this is a total mixture of spirogram. और जिसमें आपको सारी चीजें मेंशन करनी है, तो I will try to simplify. Just see the ratio. If it is not greater than 70% and vital capacity is also greater than 80%, this is a pure obstruction. Now, on the basis of two things, reversibility or DLCO, asthma patients usually do not have any difficulty or any diffusion lung capacity. So they have normal DLCO. But in emphysema or COPD, when there is distortion of the lung parenchyma, gas exchange decreases. These patients will have reduced DLCO. क्योंकि हर जगह setups पे DLCO आप नहीं करते हो, तो what you do the reversibility testing. Can anyone tell me what is reversibility? In an asthma patient, when will you say there is reversibility and patient should be labeled as asthma?
And the DLC is more than normal.
Sorry, please tell me again what you are saying.
When the DLC value is more than normal, it would be a reversible disease asthma.
You are saying about DLCO?
Yes, sir.
No. We usually do not measure DLCO. It is we have a different machines for DLCO. So spirometry cannot comment on DLCO. I am asking you on the basis.
Sir,
Anyone else?
FEV1 is greater than 12% on
Yes,
bronchodilator.
this is the definition of reversibility. After using short-acting bronchodilator, FEV1 increases 12% and 200 ml. This is called reversible obstructive lung disease. This is reversibility testing performed in obstructive airway disease, commonly asthma. Spirometry before and 10 to 15 minutes after administering a short-acting bronchodilator like Ventolin or anything, either with inhaler or nebulizer. And what you do, you calculate post bronchodilator FEV1 minus pre-bronchodilator FEV1 divided by FEV1. This shows the reversibility formula. This is reversibility formula. You don't have to remember this. Just remember that this formula will tell you there is 12% improvement in FEV1 and an absolute improvement of 0.2 liters or 200 ml. Basically, if someone's FEV1, let's suppose, was before bronchodilator, it was 1.2 liters, means 1200 ml. And after bronchodilator, it increases to 1500 ml. So it is understood there is more than 200 ml reversibility. So this is called reversible obstructive lung disease. And when you label it as reversible obstructive lung disease, it is called asthma. And if you observe that even after bronchodilator response, there is not much reversibility. Let's suppose that same guy had 1200 ml FEV1, and after using bronchodilator, it increases to 1250 or 1300, just an increase of 100 ml. This is an irreversible or partially reversible obstructive lung disease. This is not asthma. You have to label it as emphysema COPD, depending on your history. If patient had post TB and has bronchiectasis on your X-rays, then it is bronchiectasis. If patient was a smoker and you find hyperinflated lung fields, it will become COPD. Everyone is on this with me. Any questions you want to ask here? Anyone wants to ask any question, please ask. I know this is a bit slight difficult in making you understand over Zoom. It would have been easy for me in if I was in an actual lecture, but I want you to understand this because this is very important. Any questions? Okay, I'm going further. We still have ABGs remaining. What time is it? How many time I have left, Yusra?
Sir, we have 5 minutes more.
Only 5 minutes, Yusra. This I was asked to do two lectures in one, spirometry and ABGs. Both are important topics.
Yes, sir.
Okay, let's see if I can complete spirometry today.
Okay.
Achha, this is a flow volume loop. You can see this is a normal spirogram and this is an obstructive spirometry. See the concavity. This is restrictive. Lung volumes are very much restrictive. And when you see flattening of the expiratory limb as well as the inspiratory limb, you can see there is a oval shaped spirogram. This is called fixed central or upper airway obstruction. And if you see the expiratory limb is normal, but there is a flattening of inspiratory limb. This is called variable airway obstruction. And if there is flattening of the expiratory limb, this is called incomplete exhalation. Let me show you another thing. Now, in addition to the obstructive and restrictive pattern, flow volume loops can provide information on upper airway obstruction, fixed obstruction, constant airflow limitation on inspiration and expiration, such as in tracheal tumor, tracheal stenosis. They are speaking about this curve. You can see constant limitation in expiratory and inspiratory limb. This is called fixed airway obstruction. It happens in any tumor obstructing the major airways like trachea or carina or bronchus. And when there is variable extrathoracic obstruction, when they say variable extrathoracic obstruction, usually inspiratory limb gets flattens. Limitation of inspiratory flow or flattening of the inspiratory loop, such as in vocal cord dysfunction. I'm going to show you. This is fixed airway obstruction, fixed upper airway obstruction like post-intubation stenosis, goiter can lead to compression of the trachea, endotracheal neoplasm, bronchial stenosis. You can see flattening of both the limbs. Now, variable extrathoracic obstruction, either bilateral or unilateral vocal cord paralysis, you can see flattening of the inspiratory limb. Expiratory limb remains normal. This is called vocal cord constriction, reduced pharyngeal cross-section or airway burns. Now, variable intrathoracic obstruction. When you say intrathoracic obstruction, there is flattening of the expiratory limb. Expiratory limb becomes flattened. And it can happen in, these are tracheomalacia and polychondritis are the disease of cartilages of trachea. What happens in tracheomalacia? The cartilaginous rings become so soft and they lead to collapse of these and leading to intrathoracic obstruction. Do I have time for ABGs? Yusra?
Yes,
Because I think it will take 15 minutes more.
सर आप कंटिन्यू कर लीजिए नेक्स्ट
Okay,
क्लास
I'll try to finish it as early as possible.
यस सर
When is ABG indicated? ABGs are indicated if there is deterioration in already critical conditions, such as patient's decrease in oxygen saturation, patient getting confused, fall in conscious level, increased respiratory effort, and cyanosis. Patient getting cyanosed, you order an ABGs. Assess the ventilatory status, oxygenation, and acid-base status of the patient. Let's suppose patient is on ventilator, you have to get an ABGs whether you're fully ventilating patient or not. If a patient is of acute kidney injury and patient has acidosis, you also have to get ABGs done to assess the acid base status or assess the response to an intervention. Let's suppose a patient, asthmatic patient comes to you with, or COPD patient comes to you with severe dyspnea, you ordered an ABGs and it was showing type 2 respiratory failure initially. Then you try to manage that patient, and after 30 minutes on 1 hour, you need to see if the patient, if there is any response to your intervention. You repeat that ABGs. Now, contraindication. There is no absolute contraindication for ABGs unless patient is actively bleeding profusely. किसी को कोई blood dyscheriasis है, कोई ऐसा disorder है जिसकी वजह से वो profusely bleed कर रहा हो, then there is contraindication for absolute contraindication. Other things are AV fistula, जिस हाथ में AV fistula बना हुआ होगा, never go for ABGs with that on that hand. Bleeding dyscheriasis or bleeding diathesis, any bleeding disorder, severe peripheral vascular disease or absence of an arterial pulse. आपने पेशेंट को देखा उसकी आर्टीरियल पल्स ही नहीं है और आपने उसी के में से आपने ABGs कर ली, तो it will lead to further damage, or if there is any infection oversight. Now let me ask you which artery you want to choose for ABGs. Anyone please can answer me this, which artery you want to choose for any ABGs? I cannot hear you. I cannot hear you, please.
ब्रेक किया
क्या कह रहे हो? अच्छा चले, radial artery is the most suitable choice for performing an ABG because it is superficial, has collaterals, and easily compressed. It should always be the first choice of your ABGs. Other arteries, femoral, dorsalis pedis, can also be used. Now these are ABG reports which shows partial pressure of carbon dioxide, pH, partial pressure of oxygen, and saturation of oxygen. These are normal values. 7.35 to 45 is the normal pH. Normal PCO2 level is 35 to 45. Normal oxygen pressure is 90 to 100. Now, there are two types of respiratory. Basically, there are four types, but I'm going to tell you only two types: type 1 respiratory failure, type 2 respiratory failure. What is type 1 respiratory failure? Patient will be hypoxic, that is PO2 will be less than 60 and partial pressure of carbon dioxide will be normal or slight less. But if this carbon dioxide level starts to increase, let's suppose greater than 50, then you will label it as type 2 respiratory failure. Now, acid-based disorders, जो कि metabolic and respiratory में आप further divide करते हैं, and can be acidosis or alkalosis. Changes in acid-base disorder. When there is metabolic acidosis, the primary defect is decrease in bicarb level because bicarb is the normal buffer of the body, and which is regulated by your renal functions or kidney. Kidney regulates this bicarb level. If this bicarb level falls, it leads to metabolic acidosis. If this bicarb level increases, this will cause metabolic alkalosis. When the term respiratory is involved, always remember partial pressure of carbon dioxide will be involved. Carbon dioxide is also known as a volatile acid because when it gets absorbed in your blood, it forms carbonic acid. Carbon dioxide CO2 plus H2O forms H2O CO3, which is a carbonic acid. So if any partial pressure of carbon dioxide increases, it will lead to acidosis, which will be called respiratory acidosis. And if this level falls, it will be called respiratory alkalosis. And body has a mechanism to compensate. Compensation will always be opposite to the primary defect. If patient is having metabolic acidosis, compensation will be respiratory alkalosis. PCO2 will fall. Same goes for metabolic alkalosis. Compensation will be respiratory acidosis. Always remember, compensation will be opposite to the primary defect. Now some terms and definitions. Acidemia, pH less than 7.35 is called acidemia. Alkalemia is greater than 7.45. The process which leads to acidemia or increase in hydrogen ion is called acidosis, and the process which leads to alkalemia is called alkalosis. In respiratory acidosis, pH will fall with increase in PCO2. Basically, this is the same chart I told you. The causes of respiratory acidosis can be central, like any sedative given, which will depress your respiratory system. And whenever there is hypoventilation or reduced respiration, PCO2 will rise. Patient had a stroke, infection, asthma, COPD, emphysematous lung, pneumoconiosis, bronchitis, ARDS will lead to respiratory acidosis. If patient has any neuromuscular disability like polio, kyphoscoliosis, usually these patient tends to have increased carbon dioxide level. Other can be obesity, OSA, or hypoventilation syndrome. Respiratory alkalosis occurs when hyperventilation reduces carbon dioxide value or carbon dioxide pressure. In respiratory alkalosis, pH will increase and PCO2 will decrease, and carbon dioxide will rise, also decrease as a compensation, because respiratory alkalosis will lead to metabolic acidosis, and in which bicarb level will reduce. These are the causes of respiratory alkalosis: CNS stimulation, pain, anxiety, psychosis, fever, severe hypoxemia like high altitude, pneumonia, pulmonary edema, aspiration, severe anemic. These will all lead to hypoxemia. In turn, patient will try to compensate by hyperventilating, leading to respiratory alkalosis. Drugs or hormones, pregnancy, progesterone, salicylate, cardiac failure, anything leading to chest receptor stimulation like pneumothorax, hemothorax, pleural effusion, patient will try to compensate with increased respiratory rate. Metabolic acidosis, whenever there is term acidosis, it is understood that pH will decrease, and if it is said metabolic, so it is understood bicarb will decrease. Causes of high anion gap metabolic acidosis are lactic acidosis, ketoacidosis, diabetic, alcoholic or starvation leading to ketoacidosis, toxins, ethylene glycol, methanol, salicylate, propylene glycol, or renal failure. All these leads to metabolic acidosis. Causes of metabolic acidosis: non-anion gap, nausea, vomiting. Patient has vomiting and leads to bicarb loss, renal acidosis. Any drug usage of prolonged drug like potassium sparing diuretics, trimethoprim, NSAIDs. For metabolic alkalosis, alkalemia or pH will increase because the term alkalosis is used. Primary defect is increase in serum bicarb. These are causes of respiratory alkalosis. Just remember these things. Sorry, I have to go fast in the last because ABGs is completely another topic. Red flags, always remember, if you see a pH less than 7.25, be attentive. This patient will soon going to collapse because it is not survivable to remain on pH less than 7.3. All these are red flags. If you find pH less than 7.25, partial pressure of oxygen less than 60, and PCO2 greater than 50, this means there's something wrong with the patient, and soon this patient will collapse and something will happen. So always these are called the red flags. You have to act fast if you see these things. How to manage? Oxygenate